USMLE style question. A 55-year-old man is brought to the emergency department from a nursing home due to altered mental status and fever for the past several hours. He has a history of diabetes mellitus and chronic kidney disease. Vital signs: beep 7540 millimeter Hg, HR 24 breaths min, temp 39.2 degrees Kelvin 5 Cufure, oxygen sat 96% on room air. On physical examination, skin is warm and flushed. Capillary refill is brisk. No jugular venous distension, JVD. Lungs are clear. Urinalysis shows leukocyte esterase and nitrites. Which of the following best describes this patient's underlying hemodynamic abnormality? A. Decreased systemic vascular resistance, SVR, and increased cardiac output, CO. B. Increased SVR and decreased CO. C. Decreased pulmonary capillary wedge pressure, PCWP, and increased SVR. D. Increased PCWP and decreased COE, increased SVR, and increased an explanation. Correct answer: A. Decreased systemic vascular resistance, SVR, and increased cardiac output, CO. This patient is in distributive shock due to septic shock, likely from urosepsis, based on fever, altered mental status, and positive urinalysis. Key hemodynamic changes in distributive shock, e.g. septic shock, anaphylaxis, neurogenic shock, SVR, severe vasodilation, warm, flushed skin, CO, initially compensatory due to hyperdynamic circulation, or normal PCWP, preload may be low or normal, BP, due to vasodilation. Septic shock mechanism, inflammatory cytokines, TNF-A, IL-1, IL-6, widespread vasodilation, capillary leakage, hypotension, tissue hypoxia despite high cardiac output. Management: aggressive IV fluid resuscitation, 30 milliliters per kilogram crystalloid bolus. Broad-spectrum antibiotics, e.g. piperacillin tazobactam plus vancomycin. Vasopressors, norepinephrine, if persistent hypotension. Why not the other options? B. Increased SVR and decreased CO, seen in cardiogenic shock, where the heart fails to pump effectively. C. Decreased PCWP and increased SVR, seen in hypovolemic shock, where preload is low but SVR is high. D. Increased PCWP and decreased CO, seen in cardiogenic shock, e.g. acute MI heart failure. E. Increased SVR and increased PCWP, seen in obstructive shock, cardiac tamponade PE. Key takeaways for distributive septic shock: warm, flushed skin, low BP, hot classic signs. Hemodynamics: SVR, pop PCWP. Treat with IV fluids, antibiotics, and vasopressors.